Go to hyperthyroidism now. So this is the other problem. This is also having two types. So either it's autoimmune. If it's autoimmune, we call it Graves' disease. Here, this is the autoimmune form. This is also the most common type. And then there's also the iatrogenic, which is again, what's the cause for the iatrogenic here? Treatment for hypothyroidism. So if you're treating someone with hypo, they could become hyper. Okay, so that's the other type. Manifestations, all the opposite of hypothyroidism. So this time, what will happen to the patient's mental status? Yeah, very hyperactive. Okay, so restless, they can't keep a single thought. Okay, there's always like very easily distracted. Yeah, think of a chicken, right? Have you seen a chicken?
Oh, yeah.
Chicken will be like, yeah, they'll look like a chicken, and they'll lose weight. Okay, these are people are skinny, they're sweating all the time. Okay, they can't tolerate heat. Okay, so in the middle of winter, they'll have tank tops on. Okay, they'll complain so hot. Okay, blood pressure so high, heart rate so high, sweating. Yeah.
The surprise look, that's the Graves with the
Yeah, so
eyeballs.
we'll have the
Oh.
picture here. Yes, correct. There will be exophthalmos. Okay. So they're irritable, restless, heat intolerance. Again, they'll have increased appetite, but despite the voracious appetite, they'll actually keep losing weight, meaning that's how high their metabolic rate is, meaning there's not enough time in the day to eat to support their metabolic needs. So therefore, when they do get to sleep, however, the short hours that they sleep, they still continue to burn energy because their heart rate's always high. Okay, so therefore, so they'll go into a catabolic state. Okay, meaning their protein will be broken down. Okay, the muscles will be used for energy. Okay, there's no fat in these people. They have the, like Fernando mentioned, they'll have exophthalmos, meaning they'll have the eye protruding out. That's actually a more of an illusion. Okay, so we'll look at it why or later. Um, so because there's eyelid retraction, so let's say imagine yourself with no eyelid. So no eyelid right here. What will your eye look like? Of
Yeah.
course, it will look like it's protruding out, right? So that's the problem here. So because the eyelids retracted, can you blink? No, very, very difficult to blink. So what will happen to the eyes now? You can't blink. So therefore, it will dry up. It'll be very red, very irritated, painful. Okay. Plus, there's increased fat deposit also in the back of the eyeball. So that will help push the eyeball forward at the same time. You've probably seen commercials on TV about TED, thyroid eye disease. This is it. Okay, so it requires treatment if you develop that. There are, oh, we forgot about the menstruation changes in hypo. So in hypo, they'll have less ovulation. And then, of course, is there any sex drive in hypothyroidism? None. Okay, so now decreased libido. Here, though, they are very, um, yeah, so highly sexually active, very horny. Okay, but they cannot conceive just the same because there's problems with lack of menstruation. They cannot menstruate now. So therefore, very hard to conceive. Okay. So everything, they're sweating, like I said. Okay. And then the cardiac here is our main concern. The patient could have a heart attack as a result, or they could have a stroke because of the extremely high blood pressure. Okay. So when the patients are admitted like this, they're always in a cardiac unit. Okay, so we'll look at management shortly. So already talked about the hypertension and the tachycardia that will the most of the cardiac symptoms. Patient will have palpitations. And as already mentioned, patient's heart rate is so high that the patient's heart will eventually fail. Okay? They could either have a heart attack or some other cardiac complication. The treatment for hyperthyroidism depends. What does the patient have? Is it Graves' disease, or is it is it because of too much thyroid replacement dose? Unlike hypothyroidism, wherein the treatment was the same regardless of the type, right? Whether it's Hashimoto or iatrogenic, the same treatment you were given, levothyroxine. Here, treatment well depends. What is the problem? Is your problem Graves' disease, or is it iatrogenic? So if it's iatrogenic, of course, since what's the cost if it's iatrogenic? The dose of the hormone replacement was too much. So therefore, what do we do? Adjust it down. Okay, as simple as that. If it's Graves' disease, however, we have a few options. So as already mentioned, the treatment depends on the underlying cause. What is your hyperthyroidism caused by? Is it Graves' disease or iatrogenic? Now, if it is Graves' disease, which again is the most common type, one choice is radioactive iodine. Medications first, antithyroid agents. There are two. Then we've got radioactive iodine, which I described earlier under the testing, and then there's surgery. Which one the patient will receive depends on the patient's age and maternal status. They're pregnant, is it an option to do medication and radioactive? No. So the only option would be surgery. There are symptomatic treatment as well, because what do we do with the cardiac function? Patient's blood pressure is so high, heart rate so high. Do we treat that? Yes, we give beta blockers for that. Okay? But keep in mind that the beta blocker here does not alter the thyroid function. This is simply to manage the cardiac symptoms. Are we clear? Okay. But it's, of course, part of treatment. Okay. And what is always the result? Regardless of what we choose or the patient and the doctor chooses, what's the result of any of these three therapies? Hypothyroidism will result. Okay, there's no other scenario, right? Okay. If the patient has hypothyroidism, that means usually they have goiter. Okay. So if surgery is planned, they can't do that right away. They have to put the patient on either radioactive iodine or antithyroid medications first, because you cannot resect the thyroid gland if it's enlarged. Because why is it so big? What's making it big? So same idea as why is erect penis so big? What makes the penis so big? Blood flow, right? Okay, so therefore, if the thyroid gland is so big, that means what's happening to the blood flow? Very high blood flow. And what will happen if you cut it out? You'll be guaranteed hemorrhage. A patient will die right there on the operating table. So we cannot do surgery right away. So we have to do other options first. So it's either antithyroid therapy or first, or radioactive iodine. If the patient is pregnant, the doctor will decide, because the options I'll show you later. There are options, since there are only two antithyroid medications. One of them crosses the placental barrier. So therefore, one drug is not an option during the first trimester. So they'll have to use the other medication. Okay. Okay, let's start with drug therapy first. So what are the drugs and what do these drugs do? They're called antithyroid. So therefore, what will these drugs do? They're anti-thyroid. So when, just like antibiotics, what do antibiotics do? Kill bacteria. So what will this do? Antithyroid. It will kill the thyroid. Okay, so that's why it results in, what's the result? Hypothyroidism. Okay, so there are the drugs are below. So let's do radioactive iodine, I guess. So radioactive iodine therapy. So you swallow this This is the RAI 131. As I mentioned earlier, so women of childbearing age, we make sure we test for pregnancy first before choosing this option. And once they're started on it, then they're told not to conceive for at least 6 months after the treatment. So therefore, what will be part of the education once we put them on it? Well, you speak for yourself, no sex. So what's the more practical, realistic option? Okay, so how many methods? Should be two, right? Because you don't want to have babies while having radioactive iodine, right? So what will this child look like if they're exposed to radioactive? Yeah, you don't want to see what this baby will look like, right? So two methods of birth control while on this, right? So for 6 months, okay. And then no breastfeeding as well, 6 weeks. All right. So just like antithyroid medications, the radioactive iodine, of course, you're now exposing your thyroid gland to high doses of radiation. So what will happen to the thyroid gland? It'll be destroyed. Okay, so what's again the result? Hypothyroidism. Now, since it's radioactive iodine and you swallowed it, are you radioactive? Yes, the patient is radioactive here. And since the patient swallowed it, it will enter body fluids. Okay. So therefore, what precautions should this patient take? Since it enters body fluids. Okay, so anything wet coming out of this patient will have radioactivity, right? So we're talking saliva. So can you kiss? No, you probably need a plastic bag, okay? So you put a plastic bag over the person and then go ahead and kiss, okay? But you cannot have contact with any body fluids. Are we clear? So saliva, reproductive secretions as well. Blood, urine, feces. So anything, again, wet, with the exception of sweat. Sweat's fine. But anything else is radioactive. Are we clear? So take care of those. So let's go in the house. So patient's body fluids are radioactive. Let's say you only have one bathroom in the apartment. You have a one bedroom apartment. Co-op. One bathroom. So what do? Have them go on a bucket? What do we do? Well, I gotta go, man. You can't schedule me. Okay, so you make sure you clean. How many times do I flush? At least two. Okay, make sure it's clear, right? Right. Well, it's not really bacteria, so you don't need Lysol. Okay, it's not bacteria, it's radioactive. Okay, so you just need to get those fluids out. Okay. Laundry. We only have one washer and dryer. We share that. So what do? Okay, make sure you run the machine empty, okay, for one full cycle, okay, before anybody else can wash their clothes in there. What about the utensils at home? Okay, so toothbrushes, we assume, right, that we don't share toothbrushes, yeah? But since the textbook says it, so I guess some people do. Yeah. Food as well, like leftover food, okay, anything that has saliva on it, glasses, cups, towels, okay? So just be creative, okay, on how to do the teachings, okay? All right. So we had myxedema coma as a complication for hypothyroidism, yeah? We also have a life-threatening complication here. So an untreated hyperthyroid patient, or as well as a hyperthyroid patient who is exposed to stress. Because what is thyroid storm? This is again a life-threatening condition of severe hyperthyroidism. Okay, so let's talk about really high blood pressure, really high heart rate. So this patient will die, okay, from a heart attack, hypertensive crisis. No, they'll have a stroke. All right, they'll die. Okay, the trigger for thyroid storm is this. So a hyperthyroid patient, a Graves' disease patient, if they have any stressful stimuli. What is stressful stimuli? What if you have someone who you just hate just for being that person? Okay. Do you have anybody like that? Like you hate somebody, you don't even know them, but you hate them? Like for example, Trump. I don't know the guy personally. I just hate him. So is that stressful? Yes. Okay. So something as minimal as that, for instance. Or let's say I got sick. Is that stressful? Yes. What else? If I have an infection, I get the flu. Is that stressful? I undergo surgery. Okay. So I undergo breakup. Okay. Let's say it might happen to between me and Sering again. Okay. So she dumped me. I have hyperthyroidism. Can that trigger thyroid storm? Yes. Can that kill me? Yes. All because of Sering. Okay. So is it dangerous? Yes. Okay.
Motion is dangerous.
So let's talk about, there's a whole chart for thyroid storm, so we'll do that a little bit later. But those are the triggers. Okay, so that's the trigger for a hyperthyroid patient to go into thyroid storm. And we'll look at the manifestations because it's a life-threatening emergency, so we need to recognize the signs and symptoms, and then followed by management. So for thyroid storm, so here's the chart, 45-6. So we've got the trigger again are what? Is the trigger very specific or is it vague? Okay, it's specific to the person, right? Whatever is stressful to you. So can you have a thyroid storm during examinations? Yes. All right.
That's the proper term.
Thyroid storm, that's the official term. So what are the manifestations? The earliest manifestation is a rise in body temperature. Take note that it doesn't have to be fever. Okay, a rise from the baseline body temperature. So let's say this patient's baseline temperature is 97.8. 98.8, is that fever? That's absolutely normal, but that is already a sign of thyroid storm. Remember, it doesn't have to be fever. It can be just a 1 degree rise, okay, from baseline. I repeat, 1 degree rise, which doesn't have to be necessarily a fever. Are we clear? So don't wait for, let's say the patient's temperature was 96 and then they're 97, 98, and then you do nothing because that's normal. Is it really normal in a hyperthyroid patient? No, that's already a sign of thyroid storm, an early sign. Then we get extreme tachycardia, and then again, the extreme manifestations of hyperthyroidism, especially the cardiac symptoms. And then, of course, the patient will have mental status changes. Usually there's a decrease in the level of consciousness, indicating that the patients may be having a stroke already, okay, increased intracranial pressure because of the severe hypertension. Okay, management. So the important part is you activating rapid response. Okay, so call rapid response team, alert the doctor right away, and then prepare to do the following. So in no particular order. So you just because this is life threatening, we can do everything here. So even though it says here, oh, cooling the patient, is that really as important as giving oxygen? Yes, because the body temperature here will cause further symptoms, right? So therefore, any of these are equally important. So somebody's putting on ice, for instance, or a hypothermia blanket. Patients already, somebody's giving oxygen or intubating the patient if needed. Somebody's starting IV fluids. And then these drugs here, These are the two antithyroid medications, which we'll discuss a little bit a little later. Hydrocortisone, this is to treat shock or adrenal insufficiency. Okay, so this is IV push. Then iodine is also given, a lot of iodine. We'll discuss why in a minute. Then for the cardiac problems, we'll of course have to treat them, okay, either with antidysrhythmics, specifically beta blocker therapy, or digoxin. Okay, we already talked about the radioactive iodine precautions earlier, okay, and a lot more than what the book said. Here are the antithyroid medications. We have two. Now, how do these drugs work? Here's your answer. They block the utilization of iodine by interfering with the iodination of tyrosine. So basically, in English, it means, does it allow the thyroid gland to form T3, T4? No. No. How? By blocking iodine uptake, meaning it doesn't, because you need iodine to make T3, T4. So if you're blocking thyroid uptake of iodine, can you make T3, T4? No. So that's how the drugs work. So there are again two drugs. You've got methimazole or propylthiouracil, or just call it PTU. In clinical, I don't usually see PTU or propylthiouracil. What we see will be methimazole. Okay, so this is the more commonly prescribed drug over the two. However, keep in mind that this drug, how does it work again? Prevents iodine from binding in the thyroid gland. So if iodine can't bind, no T3, T4 production. Okay, keep that in mind. So here are the prior, of course, the doctor will do this. Okay, we have baseline blood work. Okay. Now, and we look at the side effects when we get to the chart. Right here. So we've got PTU, can block synthesis of thyroid hormones. These are your nursing responsibilities. And this is a common side effect. Watch for rash, nausea, vomiting. And for methimazole, same action, more toxic than PTU. So watch for rash again, same as for PTU. Now, these drugs here, beginning with sodium iodide, potassium iodide, SSKI, these are iodines. Now, why do we give iodine to a patient who already has hyperthyroidism? Because can iodine therapy cause thyroid storm? Technically, yes, because what will happen to your T3, T4 production if you give somebody more iodine? It will actually increase, right? Okay, so the principle behind giving iodine to somebody with hyperthyroidism is actually, look at the action. It will suppress the release of thyroid hormone. So it works like this, kind of like when you're already full. Let's say you're at the buffet table. You've had 3-4 trips already to the buffet table. And then someone offers you more food. Here, have another one. After 3-4 trips, what will you do? Are you still gonna take it, or you say, no, thank you? Okay, maybe later, right? That's what you're gonna say, right? You're gonna say, later, later. You didn't say no, but later, okay? This is exactly the same principle. So if you flood the thyroid glands with a lot of iodine at one time because you swallow this, what will the thyroid gland say? No. Okay, so it would actually suppress the release. However, since there's a danger that this could trigger a thyroid storm, what does the nursing responsibility say? So if you're ever going to give iodine to a hyperthyroid patient, what must you make sure you've already given 1 hour ago? Methimazole or PTU. Okay, why again? Why give these drugs first before iodine? How do these drugs work? Block right here. So it will prevent iodine from binding right here. So it says here, how do the drugs work? Yeah, basically they prevent iodine from binding. So therefore, if you take the drug first and then give the iodine, then it will not cause a thyroid storm. It will not trigger a thyroid storm because you already took methimazole or PTU. All right. So who will get iodine solutions besides thyroid storm? Well, we also give iodine solutions if we're preparing the patient for surgery. So let's say we're planning surgery, right? So we're giving antithyroid. The doctor will add iodine therapy because since it's going to suppress thyroid activity basically, right? Because if you're suppressing thyroid hormone release, then therefore you're suppressing basically thyroid activity. So what will happen to blood supply and blood flow to the thyroid gland now? It will decrease. So what will happen to the size and vascularity of that gland? It will decrease. Can we now surgically remove it? Safely, yes. Okay. So you usually do this about 2 weeks before surgery. So a patient will be given um, iodine solutions with antithyroid medications, of course. Okay, so they're never given alone. Okay? It's always the iodine preparations plus the antithyroid. So either methimazole or BTU. Propranolol, what's the use again? What's the purpose of this drug? Yeah, what does it do for the hyperthyroid patient? For the, does it affect iodine uptake? Does it affect thyroid activity? What is this for there only? Just the it's cardiac manifestations only. Decrease heart rate, decrease blood pressure. All right. Okay, we discussed SSKI. So this is for surgery. Okay. So surgery is always planned ahead. We do antithyroid or radioactive iodine therapy first before we can do surgery. Now, there's two ways to do surgery. We either take out the entire thyroid gland or only a portion of it, depending on the patient's problem. So let's say it's the hyperthyroidism is caused by thyroid cancer, because that can be another rare cause. If you have thyroid cancer, then you may have manifestations of hyperthyroidism. So let's say it's cancer. So do we have to necessarily remove the entire thyroid gland if it's only affecting part of it? Okay, so we can have subtotal, right? But if it's affecting the entire gland or if the patient has Graves' disease, then we have to take out the entire thyroid gland. So the result will depend. So if the patient lost the entire thyroid gland, so what's the resulting complication? Hypothyroidism. If they lost a part of it only, what's the complication? Are they hypothyroid now? They still have the remaining, there's still a piece of the thyroid gland left. We only took out maybe half. Or maybe here, 5/6. So you still have 1/6 of the thyroid gland left. So are they hypothyroid? Are they hypothyroid? Do they have a thyroid gland? Yes, they have 1/6 of it left. So are they hypothyroid? Maybe temporarily after surgery, which, for a short while, they may require hormone replacement. But does it have to be lifelong? No. Okay. So again, it depends on what was done. How much of it was removed? Are we clear? All right. Okay, let's discuss the post-op here because they didn't really mention post-op care here. Actually, they did on the nursing care, on the nursing care plan. So let's just discuss it in practical, common sense. In the BSN program I went to back home, because we only had one program at that time, only BSN. So either go to nursing school or no. So you get BSN or no. There was no associate degree during my time. There was no LPN either. So we only had one choice. So anyway, so we were required 5 major surgeries, 5 minor surgeries, and 5 deliveries, 5 cord care, and all that. 4 out of the 5 major surgeries I had, no, because you had to have major surgery means they were intubated, meaning it was using general anesthesia, right? So that's a major surgery. So 4 out of the 5 I had was thyroidectomy. Same surgeon. Okay. So of course of course the procedure gets more familiar to you, right? Because you see the same thing, and then you retracted this, and then you know what's gonna happen next. Oh, he's gonna cut this, and he needs to tie, and then I need to cut that. So you get, you get familiar with the procedure, right? After the third or fourth, I knew what to do, right? So what happens is after surgery, so with all that, right? So you can see the trachea right there. So the doctor will ask you, okay, so, use a retractor. Okay, so can you move this, move the trachea here a little bit and then move this muscle. So it's very traumatic here, right? So what will happen? What do you expect to happen after this patient, after the incision is closed? So what's the dangers here? That's the least of your concern, because this is all sterile procedure. So that's the least of your concern, is an infection. So what's more, the trachea is right behind the breathing would be number one, airway, right? So we have airway problem. Remember, this patient was also intubated. Okay, so we have trauma here with a plastic airway, plus there's trauma here to the actual trachea. So airway problems. What else? Describe what I did. Okay, it's a lot of well, the swallowing would be, it's the esophagus is behind the trachea. It's not really a problem. What else is here? Will there be a laryngeal? The larynx is right here, right? So could there be laryngeal injury? Okay, so airway, laryngeal injury. What else? Can I have bleeding? Yes. Okay, bleeding. Okay. And then finally, number 4 would be, what organs are attached to the thyroid gland? The parathyroid glands. There are 4. Okay, let's go back to the anatomy. Okay. Physiology. Okay. So we don't have a posterior view of the thyroid gland. So that's your thyroid gland. There are 4 parathyroid glands behind it. So 2 on top, 2 below. So 2 here, 2 here, attached. So therefore, it's like it's the size of a mole. Okay, so you have a mole somewhere in your body, right? So it's like a small mole attached to the thyroid gland, posterior to the thyroid gland. So therefore, can you separate that little mole and its blood supply from the thyroid gland? Is it possible? You're gonna slice it out, and then where are you gonna put it? Just leave it hanging there? So of course not, right? It's part of the thyroid gland. It's like a gland inside a gland. Okay, so that's where your parathyroid glands are attached, at the back of the thyroid gland. So when you surgically remove the thyroid glands, what will happen to the parathyroid glands? They're gone as well. Okay, so you end up, they're naturally removed as well. Okay, I mean, where are you gonna put it again? Can you pluck it out and then somehow leave the blood supply to it? And then again, where are you gonna put it? Staple it on the staple or tape it again, glue it against a muscle or something? No, of course, it's gonna be taken out as well. You understand? Okay. So as a result, what will happen? The only function of the parathyroid gland is to release parathyroid hormone, and the function of the parathyroid hormone is only to increase serum calcium levels. So, if you lose the parathyroid gland or glands, what will happen to the patient's serum calcium levels? It will decrease. So, what's your concern there? Hypocalcemia. Patient will suffer hypocalcemia. So after thyroidectomy, always watch the patient for hypocalcemia because it will happen. Okay, depending again, did we take out the entire thyroid gland or was it only a portion? Okay, so if it's the entire thyroid gland, then is it if or when the patient goes hypocalcemic? It's when. What if the patient only lost a part of the thyroid gland? Is it if or when? If. Very good, children. And what are the manifestations of hypocalcemia?
Trudeau sign and Chevron
Very good.
sign.
So Trousseau sign, and Chavostics. Okay, so those are your manifestations. Of course, we have cardiac. Again, I won't test cardiac manifestations yet because we haven't done module 8, but you should know about tetany already, right? So Chavostics and Trousseau sign. And of course, the GI functions the patient will have. If it's hypocalcemia, then it's usually constipation, nausea, vomiting, and some muscle weakness as well. For bleeding, take note that because what position will this patient be after surgery? What position in bed? Flat? Okay, they will be on Fowler's or high Fowler's. So therefore, since the incision is here, because they cut it here like a bikini right here. So they slice your neck right here and it's glued shut. And the dressing's here. So if your Fowler's like this, where will the blood go? Down here or back here? It will go in the back, actually. So don't just check for bleeding in front, check for bleeding the back of the neck because of that position. So what's the treatment if the patient does have signs of tetany? IV calcium chloride or calcium gluconate. Okay? Immediately. All right, that's it for today. We'll continue with